think whenever you're ready, Russ.
Yeah, the numbers I'm seeing are just accumulating. I'm pretty sure we should have over 100, but maybe not. So for those of you that are joining us, I think we're going to have a pretty good attendance, but we are doing this sequentially. So I'm going to wait one more minute, but I want to welcome all of you, and we're going to have an exciting discussion today that I'm sure most of you are anticipating as soon as I get done jabbering here, but I am going to wait just another minute because it looks like the participant number is still increasing, so we don't need to repeat things. Okay, we may be stabilizing a bit, so I'm going to go ahead with introductions anyway. The first thing that I want to say, and I'll repeat it again, is please use chat. I think that's one of the great things about virtual things is we can do that and extend and enliven the conversation. And sometimes panelists can even answer you in chat when you do that. So with no further ado, and very briefly, so we can get going, I'm Russ Glasgow, and I'm your moderator today. And we have an incredible panel. I have to tell you, in preparing for this has been by far the most fun panel that I've interacted with to get ready. So I think we have a treat. We did have to debate recently, the last couple of days, whether this was going to be a poetry slam event or if we were going to stick to talking about outcomes in implementation science. But since that's what we promised you, we did decide to do that. So I'm just going to give a one-line introduction to each of our great speakers. And then what they're going to do is go through very quickly, approximately 5 minutes, slightly longer, a kind of key points from the outcomes framework that they've worked with the most. And then that will let us reserve plenty of time for cross-cutting discussions and things. I may well start out with, just to get us rolling, like one structured question we have for the panel. But in general, we should have plenty of time for your thing, and I will use chat to kind of select the questions. So to get rolling then, in terms of the slide that you can see there, we're going to go in a slightly different order to talk about or emulate the temporal sequence, or when these different implementation outcomes models came about. But Laura Damschroder is going to start us off. Laura, as most of you probably know, is from the VA Ann Arbor Center for Clinical Management Research, and of course, the key lead and originator of the CFIR framework and recent innovation. Rebecca Lengnick-Hall is from Brown University. She's worked closely with Enola Proctor and colleagues there, on the original, again, I'm sure pretty much all of you are familiar with the implementation outcomes framework. Our own Paul Estabrooks is the third part of the panel members. Paul has somewhat recently moved to the University of Utah College of Health. And then he has this strange thing called REAIM framework that he's going to be talking about today that I'm sure most of you haven't heard much about at all. But with no further ado, why don't we go ahead and go to the slides? I'll turn it over. I believe Paul is first here.
Yes. Thank you. Can you hear me okay, Russ? Great. Well, I will just start by saying I'm excited to be part of the panel and to give you a little bit of rundown on the REAIM framework. And, I'll kind of start with the logo on the screen, and it really documents or kind of depicts how REAIM was developed with a goal to improve the relevance of intervention research and also provide a method to try and evaluate population health impact. And implicit within that goal is a focus on planning and designing interventions for broad reach and adoption that could also be implemented with a high degree of quality by a variety of different folks and sustained within clinical or typical community and clinical settings. And to improve generalizability, the framework also has a really strong emphasis on representativeness. And so that's representativeness of participants, representativeness of implementation staff and settings. And it has an implicit goal really to focus on populations that are experiencing disparities or those that could benefit most from an intervention and are often the least likely to engage in research or the groups that we have the least information about what might work to improve health. And for those who are looking for some applications of REAIM, the first place I'd point you to is a recent ebook that was published on the Frontiers of Public Health. And the nice thing about this ebook is that there's 21 articles that focus on REAIM, but it has a good balance of information related to how REAIM's been used in practice settings for planning and evaluation, as well as how it's been used in clinical and community settings to try and advance dissemination and implementation science. I'd also say that I've got the link for the ebook here on the slides, and another place obviously that we love for people to go for resources related to REAIM is www.reaim.org. Again, that's on the slide, and we will put this webinar as well as our slides up on reaim.org when we're completed. Now, for a more singular example, I'm going to share a little bit about a project that's led by Drs. Jenny Hill and Kate Heelan. And their team used REAIM within the context of developing and testing resources to support community adoption, implementation, and maintenance of pediatric weight management interventions as part of the CDC CORD 3.0, which is the Childhood Obesity Research Demonstration Projects. And what they did in their project, and it's represented here in the implementation research logic model, they identified mechanisms of change for each REAIM outcome. And then they mapped strategies to those mechanisms with an objective to enhance all the REAIM dimensions across their pilot project. And one of the strategies that they used was to adapt Epstein's traffic light diet into a one-stop shop electronic implementation blueprint that was intended to support community adoption and implementation of the intervention. And the blueprint in turn was hypothesized to reduce intervention complexity and increase compatibility for small rural communities. And by doing that, they hoped that they would improve the number of programs that were available in rural communities where obesity is more prevalent than in urban areas. So even though Drs. Heelan and Hill have one pilot project that was intended to address all REAIM dimensions, one of the challenges that folks have when they use REAIM is that there can be an all or nothing attitude, and that is that you have to try and have strategies to change every one of the REAIM dimensions. And the way we've used it in our research group is more that REAIM acts as a way to guide a program of research. And in each project, we've used all dimensions of REAIM in the planning process, but then typically are pragmatic about testing intervention or strategies related to one or two dimensions in any given trial. The next two challenges that I have listed up here really are fundamental to a developing field of science. And when we think about how REAIM started, it started with a set of outcomes focused on balancing internal and external validity to develop more generalizable and impactful interventions and a way to evaluate those interventions across multiple levels. But it wasn't really developed initially to be a comprehensive framework for dissemination and implementation research. And so to address this over the years, there's been a number of progressions. PRISM was introduced that to provide some guidance around mechanisms of change across REAM dimensions. And then, there's been a lot of good articles that have been focusing on how REAM can be used as a more comprehensive approach to dissemination and implementation research. And one example that I'm a little biased about, but I think is a great example from one of my early career colleagues, Dr. Catherine Riley. And what we focused on in this paper was to try and come to terms with, where's the alignments between the implementation outcome framework and REAIM, and how can we reconcile some of these things to try and advance the field of dissemination implementation science. And so, some of the things that Dr. Riley and her colleagues did in this paper was separating antecedents and predictors of REAIM outcomes from the outcomes themselves, and then adding temporality to how we consider these constructs so that we would be able to do more advanced iterative planning and evaluation methods to make improvements across REAIM outcomes. And so the nice thing about this paper and others like it is that it provides us with a really good foundation for new dissemination implementation science research questions and methods by which we can evaluate those. And so with that broad, very brief description and resources, I'm going to turn my time over now to Dr. Lengnick-Hall, and she's going to talk about the implementation outcomes framework.
Thank you. So now we're just going to move up in the evolution a bit of the implementation outcomes research trajectory. And I'm definitely speaking on behalf of a whole team, including Dr. Enola Proctor. But as many of you know, this implementation outcomes framework, the conceptual rationale and justification we first saw in a 2009 paper, but this 2011 paper is really where it took flight. And this paper gave us the taxonomy that you see here on the left. And it also gave us a two-pronged research agenda that really gave us some clear directions about where we need to go with outcomes research in terms of conceptualization and measurement, and also theory building. And if you're wondering what the little stars are over here, this is showing some direct ties to REAIM. So adoption is obviously linked to the adoption part of REAIM. We can see fidelity in the implementation piece of REAIM, penetration here and reach in REAIM go hand in hand, as do sustainability and maintenance. And in addition to giving us this taxonomy and these definitions, the implementation outcomes framework also got us thinking about at what levels we could measure or intervene to change these outcomes, as well as the idea that certain outcomes may be salient at different phases of the implementation process. Next slide, please. So it was really hard for me to pick a practical application because I am not just elbow deep, but maybe neck deep in a scoping review that we've been working on for a couple of years. So I wanted to use this time to bring this to your attention. So when it comes to answering the question of, how have implementation outcomes been studied, we have been trying to answer that for you. And so we looked at the last 10 years of literature that cited the 2011 Proctor paper. We will soon be telling you the degree to which each of these 8 implementation outcomes has been studied, both in terms of design and context. We specifically looked for practical examples of studies that showed us treating outcomes as dependent variables in tests of implementation strategy effectiveness. And then we also really wanted to see if folks using this framework were getting at those interrelationships between implementation, service, and client outcomes. And in terms of challenges, I'm just picking one, and I picked this one because it's one that really came up for us in the scoping review. So the 2011 paper did such an excellent job of putting a stake in the ground and saying, these outcomes and these intermediate processes are worth paying attention to. And it really gave us the language and rose the awareness that this is important. So that's not the problem anymore. The problem now is, okay, a lot of people are using this taxonomy and citing this paper. How can we improve reporting so that we can figure out what we can learn from each study as well as what we can take across studies. And so a big challenge is consistent and sufficient reporting. And I wanted to just offer you a solution as well. We published 6 practical recommendations that describe what exactly these, where these reporting problems can come up, what they look like in the literature, and then an audit worksheet and list of exemplars if you either want to review your own work or try to preemptively avoid these reporting issues. And then on to Laura, yes.
All right, I am so pleased to be a part of this group today. So I'm going to talk about the recently published CFIR Outcomes Addendum. And this addendum came out of our work in updating the CFIR, soon to be submitted CFIR version 2. We identified 53 published articles with feedback about the CFIR, how ways to improve it, how it worked or didn't work in their in the published study from our literature review. And then we also had 134 authors using the CFIR in their work who provided detailed feedback through a survey. Our goal with this addendum was not to create a new framework, but to help implementation researchers articulate which outcomes their studies are proposing to address, whether it's based on REAIM or the implementation outcomes framework that Rebecca just talked about. And then our focus is on linking determinants to outcomes using rigorous methods. So based on feedback from users, we found we needed to define or describe what CFIR is and what it is not, because some users wanted to add patient determinants to the framework, and some users wanted to add an outcomes domain to the framework. And we had to explain why we're not doing either. So starting at the top of the figure, at the top left of the figure, you can see CFIR implementation determinants. These determinants, and they're basically contextual barriers and facilitators that may influence our implementation efforts. These are within the scope of the CFIR. This is what the CFIR is fundamentally designed to help identify and assess. These are determinants or factors that may explain success or failure of implementation. So then moving to the top right of the figure, you can see innovation determinants. So we feel that there are 2 main reasons that it's really important to distinguish clearly between these 2 types of determinants. For example, if we fail to achieve desired outcomes when we're implementing an innovation, we need to ask the question, is it the implementation that failed, or is it the innovation itself that failed to deliver? The second thing is that theories underlying the innovation itself are typically tied to the individuals who are expected to benefit from that innovation. So for example, patients. Determinants at this level might include constructs, patient-level constructs from the theory of planned behavior or feminist theory or theory of evolution. And the innovation itself should be designed based on those theories, whatever the underlying theories are, that in themselves contain determinants or themes or factors that guide where they, to assess, and that may be predictors of innovation effectiveness. These determinants, these constructs are very much outside the domain of the CFIR. So now going down on the right-hand side, many users already link, and we saw the title of one of the papers on one of Paul's slides, linking the CFIR with the REAIM framework. And many people use the or the implementation outcomes framework that Rebecca described. This is great, and we want to encourage people to continue to do this. We wanted to provide big buckets to help classify types of outcomes using those two frameworks as a starting point, but really users could draw from other sources of outcomes too. So the first thing to notice in our figure here is a focus on impact. And impact is following the REAIM definition of considering both reach, which inherently includes representativeness, and effectiveness. So we're talking about population level impact, but also we wanted to explicitly call out that it, and I think this is implied in REAIM, but that it also includes reach time sustainment too. So we want not only kind of shorter term impact, but also long-term sustained impact. The second thing to notice is that we bring out multiple constituents who each may care about different outcomes. And it's important to recognize this because sustainability science says that having defined outcomes for all these key constituents is important if we want sustained use. So, we all want to serve and benefit patients, but we also know that we fail to do so for a lot of different reasons. So if I, as a clinician, am expected to deliver a new treatment as a deliverer, it would behoove us as implementers to make my job easier, more joyful, or more meaningful. Maybe these are the measures that are most important for me as a deliverer, as a clinician. Leaders may care more about cost or return on investment. So very different outcomes for different constituencies. And it's important to know that, recognize that, and define those. Next, moving to the left, we make a distinction between anticipated versus actual outcomes. And anticipated are forward-looking perceptions of outcomes, and actual outcomes are kind of backward-looking assessments of outcomes or reality. And then, like the work that Paul referred to, Catherine Reilly, we also have a classification of antecedent assessments. So the bottom line intent with this figure is that we wanted to clarify the relationships between types of determinants with types of outcomes. So the next slide, I just want to show two quick cases. One is a published paper led by Andrea Nevedal, and this was, the aim was to identify factors or determinants that contribute to successful implementation and sustainment for 23 diverse practices within the VA. So we actually looked at 3 different outcomes in this work. One was shorter term 6-month implementation goals, and this was assessed qualitatively as the degree to which teams implemented all of the practice components and met their 6-month milestones. Then we also looked at sustainability. At that 6-month time point, we assessed or evaluated whether teams were anticipating being able to sustain or continue use of those practices. And we also looked at sustainment, where we went in with a survey. On average, 1.5 years later, some practices were much longer. And we asked the simple question of whether the practice was still being used. So that kind of highlights the difference between the sustainability in terms of, kind of predictions versus sustainment. Have you actually been using that practice? The next slide. The purpose with the next slide, this is based on an implementation of the diabetes prevention program within the VA, is simply to show a linkage with CFIR with the REAIM framework. And it's just to convey that different determinants matter for different outcomes. So that's why it's very important to conceptualize your outcomes, and then knowing that the determinants may be different for shorter term implementation goals versus longer term sustainment goals, for example.
Is that it, Laura?
Yep.
All right. Well, what a great tour de force to start us off. I just want to comment that it is so exciting, I think, for our field to see the continued development of all of these frameworks and where we're going. That's one of the exciting things about the field. I know for some people it's frustrating because we are evolving and learning. And as I think implicitly or woven into each of the comments from our speakers has been some challenges to applying it, and maybe sometimes from misinterpretations or things that maybe haven't come across in terms of our perspective. I would like to circle back, even though you've each commented on some of the key aspects of the frameworks that you've worked with. And again, as Laura, Paul illustrated, many of you have used combinations of them. But if we could just quickly go around, and maybe I'll reverse the order here, or not reverse, but change it out with Rebecca, then Laura, and then Paul, just to highlight what you see as maybe the unique features of the framework you're talking about today, and maybe how it's asked differently, maybe how it's different than the other frameworks. So I think that might be helpful to open up our discussion. So Rebecca, do you want to start us out on that?
Sure. And Nola and I were just talking about this yesterday. And I think what the implementation outcomes framework really did and continues to do is keep our focus on those intermediate processes and give us a focal point for understanding if and how implementation strategies work or not. And another key feature of this is how it is inextricably linked to both service and client outcomes. So I think a lot of us in implementation, we assume that successful implementation equals success on a service or client level, but the way that this framework is set up, it reminds us that we actually do still need to measure those interrelationships and make sure that all of the work that we're doing on the implementation side is translating into public health impact.
Yeah, so I think I'm next. First of all, our guide is meant to be a guide. It's targeted specifically for people who use the CFIR framework or other determinants. So it's an explanatory, kind of structure. And our goal is to not replace or even add to, but to help guide users in conceptualizing use of other outcomes frameworks. And then we're drawing on sustainability science by explicitly including, like the implementation outcomes framework, that it's important to pay attention to more than just a single constituency. And then the idea is, the big bucket. So how do we relate and conceptualize different types of explanatory determinants versus different types of outcomes?
Great. And Paul.
Yeah, I think that, the uniqueness of REAIM, I think in one way is it really that it's fairly easy to understand. And so it works very well with both community partners as well as practitioners that are doing the work. It has kind of a good face validity to it, that you need to be focusing on the population that you want to have a health benefit from. And you need to think about the representativeness of folks that engage within and benefit from the interventions that you're doing. And then it also has the focus organizationally and trying to understand how you best design interventions for broad adoption, implementation, and organizational level maintenance. And so I think the uniqueness is probably the face validity from both a practitioner and a research standpoint. And it really is an outcomes framework. It's the reach, effectiveness, adoption, implementation, maintenance at both individual and organizational levels are all relatively, I think, easily operationalized.
Okay, with an emphasis on relatively, maybe, as sometimes we see. Good things. All things are relative. Well, thank you all. That's great, and I think it addresses some of the questions we've already had. Let me do one more general one, and then I'll look at chat. And by the way, if any of you, as we go along, either want to raise other things from chat or just talk among yourselves or raise a question for the others, please do that. I think that'll make it fun, and we should have enough time. But the question I would like to hear from each of you on relates to the energy that's going on now and the activity about integrating implementation science with health equity issues. We've seen so many recent publications. There's a lot of other things going on to develop systematic tools to do this. But I'd like to ask you, if you could, just briefly articulate how you see the framework you're talking about addressing health equity issues. And maybe just to keep it alternating here, if we could this time, how about if we do Laura, Paul, and then Rebecca on that, how your framework is addressing health equity?
First of all, I think we want to make our frameworks, our guidance, broad enough, wide enough to embrace issues of equity and improving gaps in equity. And might I add, for both recipients and for delivery, for people on the delivery side as well. We need to pay attention organizationally or contextually for the deliveries as well as for recipients. And I think that's one thing that our guidance kind of explicitly brings to the table. Also, the focus on equitable population impact and really emphasizing the importance of representativeness that runs all the way through. And this is carrying the theme forward from REAIM. And I think it's important to think about representativeness, not just with REACH per se, but with all of the dimensions of REAIM, really. And then also, just the recognition of the three constituencies, again, opportunities for amplifying the voice of the recipients or patients, and also the delivery side.
Super. Paul?
Yeah, and I don't think I need to take too much time on this. As Laura said, it's really fundamental to the representativeness components or the principle within REAIM. And I would say, right from the beginning, it focused on this representativeness, but I think early on we weren't thinking quite so much about how you could use reach and representativeness specifically as a way to advance health equity. And I think that for folks, and I don't have it handy, so maybe one of our other folks could put a link in for Rachel Shelton's paper that focuses explicitly on how to address both sustainability and health equity from a REAIM perspective.
Great. And Rebecca?
Yeah, so I think similar thoughts. So how equity and implementation outcome frameworks kind of interact with each other. The implementation outcomes, like Paul just explained, can be an indicator or signal of inequity and disparities. As Laura indicated, equity can be a helpful lens for understanding the context of implementation success and failure. So why are we seeing implementation outcomes turn out the way that they are? And then I think a third thing that maybe we haven't touched on is how can we make the process of assessing these outcomes equitable? So acceptable for whom, and how are we ensuring that our measurement process is actually giving people space and the right context to really assess who this is working for or not.
Great, thank you. I can't help taking prerogative of the moderator and calling out one other of what I feel is exciting thing and a little bit transparency. I'm tangentially involved in this, but there is an effort going on now led by Borsika Rabin and a number of other colleagues from WashU as well as other places to explicitly call out this interface between implementation science theories and models and health equity ones, looking at both perspectives. And that's taking place within the context of this framework that somebody can put in their, website tool called dissemination-implementation.org, which lists, I think now, close to 130 different frameworks, but now calling out how those constructs interface with health equity and vice versa, how the health, not all, but a number of the leading health equity frameworks, evolving ones, relate to implementation science theories. So thank you all for that. We've had a couple of questions here, and I know one of the ones I get asked about REAIM is, is there some concrete guidance or places people can go for examples of how to concretely operationalize or measure, assess these constructs that you have in your model? For example, are there like survey items that have been used, validated survey items, interview guides, and things like that? So wonder if you could each talk about that, making this concrete, because I know sometimes people have challenges about translating the constructs that we have, which I do think people are increasingly coming to understand, but then when they go to operationalize that, it can be a challenge. So let's see, continuing, switching it out here. How about Paul, Laura, and then Rebecca?
Yeah, I think that this is this is always a challenge, and I feel like I can remember looking back on Laura's website as well as our REAIM website, and we try and provide guidance on how best to operationalize these outcomes, and so the quick answer is to say you can look and see for resources that are available, and from a questionnaire perspective, we are in the process of doing some validation work on questionnaires to assess REAIM outcomes from more of a self-reported perspective. But, at the end of the day for REAIM, I kind of go back to the standpoint of reach is, it's number, representativeness, and proportion. And so, the real importance on reach is figuring out what's your denominator and what are the characteristics of the intended audience. So you can actually look at, do you have significantly fewer Black participants relative to the population that you're trying to serve? And so there's very, to me, I always kind of go back to that. Effectiveness is, it's a primary outcome. And so it's usually a health outcome that there should be standardized measures for whatever health outcome you're trying to change. Implementation, I think, is the one that's probably most challenging, because is there a standardized way to look at the dose, the content, the degree to which it's implemented as intended? I think that there's a number of measures that for implementation fidelity, but a lot of times it ends up being fairly tailored to the specific evidence-based intervention that you're trying to intervene. And I won't go through all of them, but I would say that, I always like to go back to what's the constitutive definition. And I think that gives us good guidance on how to actually operationalize that and to, try and keep it as parsimonious as possible.
Great. Laura?
Yeah, on the heels of what you said, Paul, I'll just give a shout out to reaim.org, which gives some really nice practical guidance as well as examples and publications and so forth. And then I just put a link in chat for our technical assistance website, where we do have what we call our interview guide maker tool. And we also have links to known measures for constructs within the CFIR. There is not a single instrument for assessing the CFIR. There have been fairly massive efforts done to both create measures from scratch using the CFIR constructs, not for all of the constructs, but for selected ones that were salient for the particular projects producing those measures. We have some of the links on our website for those. And then there was also a big undertaking by the CIRC group, the Society for Implementation Research Collaboration, that did thank you. There's a link in the chat. Yeah. And there's a whole series of published papers about the state of measurement, which is not great. So if you're looking for a career, this is a great place to be.
Good. And Rebecca?
Yeah, I was going to mention the CIRC instrument review too, so I put the link there. I would actually say one of the tables in the original 2011 implementation outcomes framework paper is a really good place to start, because it has levels at which the outcome can be measured, and then types of data sources that you can use. So that can be a first step in operationalizing. And then I would say one thing that we've seen in our scoping review are some really great examples in the literature of where people say, here's the conceptual definition and here's how I operationalize it in my study. And this can be particularly important if you have a context or intervention, for example, a technology-based innovation that might look different in terms of how you might operationalize it. So I would definitely encourage you to find some examples that are specific to either the context or type of intervention that you are interested in.
Thank you. And if I can just double down on that recommendation from Rebecca, from my experience as a grant reviewer or even a journal article, when I think showing a table like that here, is the construct, here's kind of maybe the definition as of it, and then here's how I'm operationalizing it is great. Because I think if you heard from all the speakers, it's a little hard to reduce, and maybe in some cases not even appropriate to try and reduce everything down to one survey item or something like that on these vast constructs. But I think the notion is to kind of demonstrate that you do understand it with something like that. And I like that kind of image, if you can, of how you've operationalized that so the reviewer or the reader gets a sense of that. We've tried to do some of that. I'm pretty sure Laura does too. I can't remember exactly the CFIR website, but on REAIM, we've tried to explicitly do that. So I've just had a great question in here related to adaptations and how the framework might do. There's so much work going on now in our field, both assessing it and maybe in terms of adaptations, but a whole lot. We know that hardly ever do things work, either interventions or I might even say, in my experience, implementation strategies, perfectly throughout across all the settings and things. So we need to do and understand adaptations. I'm wondering, and starting here, it's kind of optional. I don't want to take, given the time, I don't want to force everybody to answer any questions, but please feel free whenever you have something to say on that. But I just wonder, and again, no particular order here, if you have a thought about that, about how the framework, or you could bring in other frameworks if you feel the ones we're talking about don't particularly fit the bill, can be used to help us understand and maybe even direct adaptations.
There's adaptations of the framework itself, and I think almost by definition, we're demanding edit, or another word might be, and I think Rebecca used this word, operationalize these measures or these ways of assessing, whether it's qualitative or quantitative. That is super, super important. And if they're, and I think that the definitions, probably the IOF, framework has the most specificity in terms of measurement. But certainly for REAIM and for the CFIR addendum, these are, they're broad concepts. I mean, like Paul touched on, effectiveness, that's going to totally depend on the innovation itself. In terms of adaptations of innovation or implementation strategies, there are other adaptation frameworks and guidance out there published. That's a whole nother topic.
Yeah, and maybe I'd just add to that a little bit, Laura, that, I see, and I don't know that this is from a REAIM perspective explicitly, but that adaptation can be a strategy to improve adoptability, improve implementation, improve likelihood of sustainability. So it can be a strategy as well as an outcome. And, and I really like, the Adaptome paper and the frame papers. So those two papers, I think when you kind of combine that together, gives good options for folks on how you at least specify, because I do think continuing to specify our adaptations and types of adaptations are going to help us to be able to understand which types of adaptations lead to better adoption, implementation, sustainability, for example. And maybe I'll stop there because I think maybe Rebecca has something on this one too.
Nope, I was just going to say, just to maybe just summarize in a slightly different way, I think we are moving from maybe assessing if adaptation is happening, which is where an outcome like fidelity might come in, to now thinking about how can we treat adaptation as a strategy there. So how is adaptation moving the needle on implementation outcomes that we care about?
Okay.
Maybe I'll
Rebecca-
throw one more thing in there, Russ, just related to, a lot of times we think about adaptation just as the structure. And I think that, if we're doing adaptation based on principles, so what's the function rather than the form? I think that's another area in terms of adaptation, is can we even adapt principles, or should all adaptations be based on what the functioning principles are for a given intervention?
Great, super answers, and nice job of pulling in other things outside of your own particular thing you're talking about today. I really appreciate that, broadening it as well too. Please keep the comments coming in. What I'm looking for now, we're having real robust chat. I'm not going to get to all of them, but I'm looking for similarities now as I'm moderating chat. And I do have one more question for you, but also I have a process issue here. And I think my internet is unstable. At least each of you have been freezing a little bit. So please go on if you don't hear from me or whatever. I think this group is quite capable of moderating yourself. So I'll hang in there and hopefully I'll make it through here before I have a crash or something. But I'd like to switch a little bit now and ask each of you to be somewhat self-critical, which I think you're all really good at, and it is important for us as a field. But could you think about what's been the greatest challenge that you've seen, either yourself or when other people try to use your framework here? Where have you run into difficulty? What are the areas you might need to work the most on, or just challenging for people when they try to apply your framework? No particular order here. Just you can.
I'll jump in and say, because I do have some thoughts, and one came from Manuel, can't see his last name, and how do we translate these and make these ideas, these concepts, more accessible and usable for practitioners? And this has been something that, our team is challenged with, and I think, this field of science is challenged with, because we really do try to have a foot in both worlds. The other challenge is just, helping people to understand implementation versus innovation, outcomes, and in implementation versus innovation determinants. But when we find that, it's like an epiphany, like a light bulb goes off. And when I see that, it's so exciting. But until you get there, it can be really difficult. It's like we're literally on Venus and Mars sometimes. And so I find that a challenge. So whether that's conceptual or language or whatever. But yeah. So those are just kind of two quick.
Right.
I think two others, or one is related to Laura's first one is, and this is probably a problem for the field broadly, but how do we balance measurement, operationalization, and impact at a really local and specific level, and focus on making things relevant to a specific practice problem versus how do we generate and synthesize knowledge across projects? And I think another big challenge is that our measurement and design hasn't necessarily caught up to the types of questions that we want to ask about implementations outcomes. So for example, a sneak peek for our scoping review, a lot of it is still at the descriptive level. But I think all of us here on the panel really care about more complex things like multi-level relationships and the interrelationships between implementation, service, and client outcomes, but we have to have the measurement and design capability to actually answer those questions. And so I think sometimes there's a lag between what we want to ask and what we can ask.
Yeah, I mean, there's feels like there's so many challenges. That's why we're doing this, right? Because it's hard to get this type of work done. But I think I won't reiterate what both Laura and Rebecca said, because I completely agree with those, and I think they apply to using REAIM as well. Where I think there's still constant challenge is even just kind of distinguishing between, well, what's the distinction between adoption, implementation, and sustainability, and where do you move what's the indicator of adoption, and once you've adopted, when does it become implementation, and once you're implementing, when does it become sustainability or sustainment? So I think there's still a lot of questions around that, and I think in a practice setting, sometimes when we bring that, and we're trying to do this in a participatory way, those things don't really make any difference to the practice partners. They just want to get this thing up and running, and and see how it's going. And then we're really interested in the science around that. The second thing that I would say is a real challenge is I would just nail in, and maybe it's just our work right now on reach, and that it's really easy for us to say that this is a good indicator for how we would advance health equity, looking at representativeness and assessing it, but actually strategies to achieve the recruitment of underrepresented populations and populations that experience challenges with the health outcomes we're trying to change. I think we really still haven't found great strategies to improve reach in our populations that we typically don't get to benefit from our work.
Thank you all. I noticed we're getting close to coming up on the top of the hour. I do want to be sure I have one last question for each of you. And then if we end up having a minute or two afterwards, I'll squeeze something else in. But my last general question for all of you, I would like to hear from all of you, and maybe we'll go Rebecca, Laura, and then Paul, is what do you see as the key directions for both research and practice? We've had really good discussion, including a nice suggestion for having maybe a follow-up one with practitioners thinking about this. But what do you see as the key future directions on implementation outcomes? What are the greatest needs and opportunities here?
Yeah, so it's, I actually wrote this down before our presentation, but I'm glad it's actually coming up. But yeah, building capacity in the field, both among researchers and practitioners. And that's what we really hoped to do with papers like the 6 recommendations, is break it down and give tools so that measuring these things systematically and rigorously is not just a conceptual exercise and does not feel accessible. So I think that's one direction. Secondly, I think implementation strategies and outcomes are inextricably linked. So all of the focus and things that we're doing with mechanisms is definitely a future direction for outcomes research as well, especially if strategies are accomplishing multiple outcomes or multiple outcomes are being achieved by one strategy. So kind of that complexity. And then I think really, what I would hope, and I think, we talk about in our scoping review, is 10 years from now, I hope we really are explaining and predicting more than we are describing.
Fantastic. Again, that was a bit of a softball from Rebecca, since in some ways she answered my question with their recent great publication. If you haven't seen that, in terms of 6 recommendations for presenting there, and I haven't been able to track anything. Could somebody put the link to that paper in for those of you that haven't read that? I think that's certainly one important future direction anyway. So Laura?
Yeah, so I would say rigorous methods to assess determinants, and then link those to well-defined outcomes, and then developing outcome measures that matter to real people, not just academically, abstractly important, but if leaders care about return on investment, assess return on investment, not cost effectiveness based on qualities, for example.
Thank you. That's so great. I just want to emphasize one thing that Laura has come on a couple times today, but this notion of whose perspective or whose outcome or who investment for what, and this different, that we have a lot of different stakeholders here, and that often I think we just take one, and sometimes maybe even the most detriment, just the researcher's perspective, rather than thinking about either the users or the people that have to deliver or implement these things, or the people that have to make really tough funding decisions too. So I think understanding these issues and what outcomes are important to them, maybe especially when you have to pick and choose. It's often quite challenging to use all of the, whichever framework you're using, to assess all of the different outcomes there. So I snuck in my soapbox. So Paul, we'll go back to let you have last word on this question.
Well, I guess I would say again that I agree with the other two outstanding panelists here. Where I would probably go next is related to outcomes is a better and more robust use of mixed methods, so that we're using qualitative and quantitative methods to really try and understand outcomes as well as the processes that lead to those outcomes. And then the other thing that I would say is that making sure that our science is also generalizable, that we start to move beyond the walls of healthcare settings and allow us to really focus in on dissemination implementation science in multiple settings, and then maybe even have our fields and our prominent journals address those things and acknowledge that there's a broader field of dissemination implementation science that lives outside of our big medical centers and big universities and are in these areas where disparities are happening related to health. We also have a harder time doing our dissemination implementation research there. So I think moving resources and focus into those underserved areas is a real key to moving things forward.
Thank you all. We're coming up towards the top of the hour. Sorry I didn't get to all of the questions, but we are recording this and we'll think about this. I'm sure the speakers would be, to a limited capacity, willing to follow up if you have other email comments. And this will be, the recording and the slides will be available on the REAIM website. So encourage you all to do that. And I just want to thank each of you. Again, as I started out saying, this has been one of the most fun, engaging groups I've worked with. Their panel, both behind the curtain or scenes that you didn't see before we got ready here, but also today. I think we did cover a huge amount, and it just really is exciting to see the development of our field and the collaboration. I really want to end on that note, rather than being my model's better than your model and that sort of thing that we see so often in academia. So thanks again for the three of you. That was just phenomenal. And thanks to all of you for attending today.
do we get to recite our limericks?
Yeah, go for it. If people could stay, go for it, Laura. I didn't quite tell them about that. But
There once was a team at VA who very much were groping their way. Thus the CFIR was born, growing like an acorn, and landed me with this foursome today.
Nice.
Either of you want to respond, or
Come on.
Trying to find mine. I think I can find it. Oh, where is it? Okay. Anola and her friends gave us an agenda back in 2011. At the time, this was IMPSI heaven. We learned about acceptability, fidelity, and feasibility, all packaged in a framework with 8 outcomes, not 7.
perfect. And it's up to Paul, but with the caveat, Paul, to keep it clean, was Diane mentioned in there. So.
I can't even find mine. I was trying. I closed my.
I have it. Do you want me to read yours for you, Paul?
Oh, you can read mine for me. Yes.
Okay. Research and practice are not the same, and randomized control trials can be lame. But by using humility and balancing internal with external validity, you can make research better with
REAIM.
All right. What a way to close. Thank you, Laura, for prompting us to do that. I challenge any panel to beat that for a closing. So with that, we'll close. Thank you, everybody.
Bye, everyone.
Thanks, everyone. All right. Thanks, guys.